Dr. Inam and our director from KP province to please come in, say a few words, and then we'll move on to HMIS presentation, followed by our common management units presentation. Over to you, sir.
Thank you, Adnan, and thanks for this organizing this conference. Before starting our formal presentation, I will just give you a background of Pakistan in 2-3 minutes. Pakistan is the fifth most populous country with a very devolved health system, where we have 4 provinces, 3 regions. So in this way, we are actually implementing, you can say, in 7 countries we are working, because they are all autonomous and they are all devolved. Over and above that, we have a huge health infrastructure, right from the health house at the community level to the tertiary care and specialized hospitals. So there are a lot of complexities. We have different vertical program with vertical MISs. But still, in spite of all these challenges and complexities, thanks to HISP and we as part of government of Pakistan, lead partner on DHIS2 transformation, we have made, significant progress in different provinces. Since I said we are, different provinces have different systems, so we are at different levels of implementation. The biggest challenge for us is the integration of all the health programs, MISs, including the tertiary care. Because currently we are working on the public sector, and we have a huge private sector as well. That is also a big challenge. Tertiary care is almost independent, they are autonomous, and they have their own MISs, which is also not standardized. So there is a long journey for us to have a well-integrated DHIS2 system implementation in the country. With these few words, let me invite Dr. Qasim, who is virtually representing government of Pakistan. And he will give an update, and which will be followed by Fahad. And he will be having some flavor of the DHIS2 under Global Fund programs of malaria, HIV, with more focus on TB. So thank you very much from my side. Thank you.
Thank you so much, sir. Thank you for explaining all. Esteemed guests, HISP Asia and organizer of this event, HISP Vietnam. It's an honor to be surrounded by such professionals on such platform. I would start by thanking HISP Asia for providing us an opportunity to share the DHIS implementation status in Pakistan. So here is the outline of my presentation. I'll give you the insight of provincial and regional status of DHIS2 implementation, as well as the vertical systems on DHIS2 platform, which includes a nutrition program, emergency rain and flood management system, and sick and newborn care. On the other hand, we have a tuberculosis program, which uses a DHIS2 platform and is managed by a common management unit. With starting my presentation, I would like to explain that we have 4 provinces along with 2 regions. And in these regions, HMIS is supported by HISP Pakistan. Pakistan has demonstrated a substantial expertise in implementation of DHIS2 as a health management information system across all the provinces. Moving towards Punjab, Punjab is one of the largest provinces of Pakistan, where 52% of the Pakistan's population resides. And it has rolled out DHIS2 in all the 36 districts. So it is currently fully operational in Punjab. The frequency of reporting is on daily, monthly, as well as on quarterly basis. And with moving forward, they have launched the Punjab government has launched the health facility module, which is basically developed by the University of Oslo and is customized by HISP Pakistan. This module is basically used for the assessment of health facilities And recently, two trainings were conducted in the two districts of Punjab, that is Mandi Bahauddin and Jhelum. Here are the few glimpses of the recent activities that were held in Punjab. Moving forward with Khyber Pakhtunkhwa, the other federation of Pakistan, it had with the fast pace after January, they have rolled out the DHIS2 in more than 12 districts and in total 16 districts out of 37. Currently, DHIS2 is operational in 16 districts and we are having reporting in 16. Their frequency is the same as the Punjab, on daily basis, monthly, and on the quarterly basis. Recently, the first quarterly review meeting was held, which focused on reporting the mechanism and data quality in the pilot districts. But before that, prior to this meeting, field visits were conducted to review the challenges that are being faced on the grassroots level. And their future plan is to implement DHIS2 in the remaining districts tentatively by June 2025. They are also focusing on improving the data quality and compliance. Here are a few glimpses of the recent activities which I have explained. The launch of rollout of DHIS2 HMIS in KP, the inaugural day of DHIS2 trainings, which are cascade trainings, KPK DHISL visit for comprehensive two-day trainings where they have discussed issues with the HISP Pakistan related to the software or to the field, as well as the first provincial quarterly review meeting on DHIS2 implementation in KP. Moving forward with Balochistan, Balochistan is one of the largest provinces of Pakistan in terms of area, with a scattered population, and they have rolled out DHIS2 in the 14 districts out of 36. Their frequency is not same as the other federations, reason being they are also biannually reporting, and that is for the financial aspect. They cover their financial aspects in the biannual report. They have currently trained, and the DHIS2 has started reporting on 569 health facilities, and the number of health workers trained are 1836. Their future plan is very optimistic, and they about the future potential of DHIS2, and they have shown willingness to roll out in the remaining districts. They have also planned integration like programs with programs like TB, HIV, malaria, and nutrition, etc. Here are a few glimpses of the recent activities of Balochistan. Launch of DHIS2 based HMIS in Balochistan, 5 days training of trainers on Balochistan HMIS, core committee meeting for HMIS Balochistan, and trickle down trainings. Moving forward to Sindh, Sindh is somehow lacking behind, but they are still in the planning phase, but they have finalized their reporting tools for the primary healthcare and secondary healthcare. And these tools were also developed by HISP Pakistan through mutual collaboration with the Department of Health Sindh. They have initially planned to implement DHIS2 in the 5 districts by the end of 2024, and the HISP Pakistan has assigned a DHIS2 implementer and a project manager who will support them in the routine implementation of and customization. Their future plan is to implement DHIS2 in the entire Sindh. Here are the few glimpses of activities that were held. First technical working group TWG meeting, in which they have finalized reporting tools and key aspects of DHIS2 implementation. And on the other side is the second technical working group TWG meeting, which were newly recommended indicators were discussed and finalized to be incorporated in the reporting tools. Bas. And moving towards the regions, Azad Kashmir and Gilgit-Baltistan, they have conducted TWGs where reporting tools are discussed, evaluated, and finalized. Based on these tools, HMIS has been designed and developed by DHIS2. Their future plan is to start the TOTs in the coming months, and both these regions are planning to roll out DHIS in the 5 districts by 2025. Here are a few glimpses of the Azad Jammu Kashmir and GB. And on the other hand, we have three programs or three systems, vertical systems, that are currently reporting on DHIS2. One is the nutrition aggregate system, which is a digital data package. So it's it is a digital data package developed in partnership with UNICEF, which is aligned with their guidelines, and it reports and it is used to measure the vitamin A supplementation and maternal nutrition growth monitoring. Okay, okay. Okay. So the nutrition aggregate system NUT is a digital database package developed in partnership with the UNICEF, which aims to manage nutrition related data within the DHIS2 platform. It is aligned with the UNICEF guidelines. The package is aligned with the DHIS Community Information System, CHIS, which enhance communities level data collection and analysis. Later on, it customizes the data according to the local context. Indicators used in this program are vitamin A supplementation, maternal nutrition, growth monitoring and infant and young child feeding. The second system is the rain and emergency rain and flood management system, or DHIS2 platform, which is a combination uh, and aggregate-based reporting. The key elements covered in tracker and aggregate are in the tracker, we have flood casualty program, flood medical camps information program, pregnant women in camps program, health facility flood damage program, and in aggregate system, we have infrastructure damages, availability of life-saving drugs, number of fogging machine available, and number of fogging rounds conducted. The third system is collaboration of HISP and UNICEF and Government of Pakistan. And they have piloted an online M&E module for small and sick newborn care. The module is basically a case-based enabling detailed tracking facility uh, 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 and reporting of newborn care. The pilot has been implemented in the 7 facilities across Pakistan. Uh, and their frequency is structured on daily basis. Now, I'll request Mr. Fahad Hafiz to give you insight of the Common Management Unit. Thank you.
Thank you. Uh, Thank you so much. I'll just try to quickly move through. Uh, so we at Common Management Unit at Ministry of Health Services Regulation and Coordination at federal level, we are responsible for tuberculosis, AIDS, and malaria response in the country. This is a newly department established in 2018. As per Constitution, the federal mandate is to prepare proposals, liaison with provinces, international agencies, technical and material resources to provinces, policy, strategy, guidance, disease surveillance and research, public sector personnel, principal recipients for the Global Fund grant. So as we are looking after the surveillance systems for AIDS, TB, and malaria in the country, our initial focus was to have an integrated DHIS2 for these 3 diseases, which we started in 2018. And we started with the aggregate instance for the 3 diseases in the whole country. So this was launched in 2018. And with that, we moved to tracker for tuberculosis. That was done in 2022 recently, with focus on more than 1,500 public health facilities and 5,000 plus GPs, which is also increasing day by day. So for malaria, we have DHIS2 rolled out in more than 5,000 health facilities as well. For HIV, we have a national surveillance system, which is linked to DHIS2, where the aggregate reports are recorded on monthly basis. So this is a general overview that the reporting line starts from the health facility to district and then the provincial programs towards the national program. All the data in aggregate goes into the central data surveillance. And for case-based, we have HIV and tuberculosis that is routed through the central surveillance system for reporting to the global reporting and the national reporting as well. So we have been using DHIS2 since 2018 for aggregate reporting with WHO standard packages. Now, since last year, we are focusing on tuberculosis and the tracker that is there and making it available for public and private sector. And we are focusing on making it available for use by the uh, stakeholders and partners. So a brief of the journey, I'll just go through. We started in 2018 with the aggregate, as I talked earlier. And then it took us a couple of time. We did some pilots in the tracker because it was required. We cannot go to a rollout of the whole country without doing some major pilots. So that was carried out in 2019 and 2020, where we were in 2021, where we were able to do it in mandatory case notification projects like MDR-TV. We focused on the tracker. We piloted in a federal capital for DSTB. Then the final rollout was happened in 2023. So that's our digital journey. This is a current snapshot of where we stand today. In Pakistan, right now we have 99% data completeness in terms of tracker case base that we are talking about. So 587 users were trained and 21 DHIS2 trainings throughout the country at the health facility level with more than 50% per badges were conducted. And we are at 99% completeness rate. So now what we are working on is a reporting and analysis and use of this data. For the tracker data that we have, we want to use this information for over future interventions. So a glimpse of the dashboard, if you see over here, we have integrated dashboards on the left side. You can see OIHCV and malaria dashboards are there. We have the maps available as well. We have the case-based dashboards in the country. We can monitor the performance on daily basis, on a weekly basis. Thanks to HISP Pakistan, this has all been made possible with their technical support and with the support of the partners. So there's another dashboard showing the users reporting by months because we were interested in knowing, are the users using the system? That's very important because just giving them the logins and asking them to enter the data is not important. We need to monitor what is their pattern of entering. So so the challenges for the next 2 years is transition to paperless recording. We are talking about surveillance systems. We are talking about, we have so much done in the past couple of years, but we want to make sure that we remove that paper system in the country. So this is going to be a challenge for us, but we'll try in the next 2 years that we complete this in the moment. Central organization unit management for the whole country. So as my colleagues earlier stated, that this is a country that has devolved a system, but every province is like a country. So it's a nightmare to manage such users. But we have used APIs of DHIS2 for making sure that the DHIS2 user management is done in a proper way. Same goes for the organization unit management. And another challenge is integration with existing systems in the country for flow of information of a single platform. So we have many provinces. Some have their own trackers, their own custom systems. The challenge is to integrate those with the DHIS2. That's where we need to focus on moving forward. And also the last part is the staff turnover and data completeness and validation. So these two challenges remain, whatever system we use and whatever information system we have, either it's DHIS2 or it's a custom system, because in government settings, we have staff turnover. We will have data completeness and validation issues. So we need to overcome with consistency. So on that note, I'll try to close out. Thank you so much.
Thank you very much for sharing this rich experience. And just for the time issue, we will make the only question at the end of the session. Now we will ask Sri Lanka team to present and share their experience for 15 minutes, please. I think, yeah. You can.
The DHIS2 implements in Sri Lanka, focusing on the recent implementation. So I'm Pramil Nage, representing Ministry of Health. So brief outline of what we have been doing. So we started in 2009 with capacity building, and then moved on to small scale implementations, then large scale, and then advanced. And now we are moving on to more innovative and major interventions. Right. So what are the areas we cover in Sri Lanka? So basically in the health side, we cover almost all the areas, especially in RM and CHIH. All the modules have been completed, then in surveillance and also in facility surveys. But we have not limited to health domain, so which I have already presented in past 2 sessions. So we have used DHIS2 in education sector and also in climate health, which I will not repeat in this session. And few big instances we have launched DHIS2. So one is the electronic reproductive health management information system, where we capture all the aggregate information related to reproductive health. And these was initiated in 2017, the largest, actually, we can call it the largest island-wide implementation. And so many presentations have been done on this, and so many awards have been received by this. So because of the time constraints, I won't be going into all the details. But then we have extended that reproductive health management system into phase 2 to capture the individual level information. So this is also implemented in both private and public health sector, where we capture details about individual deliveries, then maternal and neonatal deaths, then newborn screening, COVID-19 pregnancy vaccination, nutrition assessment. So this is also being successfully implemented and continuously now happening in Sri Lanka over a long time. Then in the COVID era, we had 2 major interventions, again discussed in a lot of forums, and I think you have already come across. So one is the surveillance platform, where Sri Lanka was the first country to respond with a digital solution for COVID-19, especially for port screening and patient surveillance. And this metadata package was reused by University of Oslo, and they distributed it, and it was reused by a lot of countries. This module contained 13 modules related to COVID-19 surveillance, and this was followed up by the immunization tracker for COVID. Again, we use this to generate the smart vaccination card for COVID-19. And this was also used by a lot of other countries after being recognized by the HISP community. Then this is one of the first mobile-based interventions in Sri Lanka using DHIS2, the district nutrition monitoring system, where we registered children with malnutrition at the field level and monitored their risk factors and also the nutritional status with their location, and also used analytics in the mobile app, which is later developed further, and then again synchronized with the central server for analysis. Then moving on to communicable diseases, DHIS2 is used in some of the vertical programs, like for malaria, we are using DHIS2 for case-based surveillance. Obviously, we have eradicated malaria, but we still continue surveillance. And then parasitological and entomological surveillance and control. And for immunization, we have the electronic national immunization program system, where we capture immunization aggregate reporting, basically from public health institutions at field level, and then the AE5 reporting. So both this system data is captured using DHIS2. And for leprosy, we have a case-based management system. So all the patients in Sri Lanka having leprosy is tracked in this system. We are enhancing this disease surveillance component in Sri Lanka using DHIS2. So currently, as you have seen, there are a lot of things happening, but vertically. So we are planning for an integrated approach, especially with the epidemiology unit, then the Family Health Bureau, which runs the ERHMIS, and also the vertical disease program. So currently we have initiated this uh, intervention because most of the immunization record is also captured in ERHMIS and also from the epidemiology unit. So we are strengthening the epidemiology unit instance to capture immunization, then supplementary immunization activities planned, especially for measles, then the AFI reporting, vaccine stock management, then disease surveillance for other diseases, and the case investigations for notifiable diseases for individual cases, and then to strengthen for public health emergencies, especially for this monkeypox. We are ready to use DHIS2, but now it's not a big threat at the moment. So if that becomes elevated, then we will be responding using these systems. And also the vertical disease program will be also integrated with these systems so that whole disease surveillance will be taking one approach. So already we have started with the weekly epidemiological diseases return and investigation of communicable diseases, and also vaccine stock information and AEFI already being developed in an integrated approach. Right. So this is another new intervention we have implemented. So this is a good example of collaboration through of various institutions and also integration of various technologies. So two aspects which we have been successfully implemented. So this is in this implementation, Ministry of Health, the Sri Lanka College of Endocrinologists, and HISP Sri Lanka in collaboration has implemented this. So what this does is it screens diabetes and hypertension from the community using these mobile apps. So there's a community screening app, and also from the clinic, once they are referred, there's another app used. So both these use OpenSRP technology. Then also we have an existing system in healthy lifestyle clinics for diabetes and hypertension. So that system is also integrated. So all these are integrated through Fire Gateway and through a Fire server and connected to a Postgres data base. And then finally, the data is passed to DHIS2 for data analysis, then decision making. So this has been successfully implemented in one district, and it is being expanded. So a good example of integration and collaboration. Then for non-communicable diseases also, we are using for mental health clinic return, and also for injury surveillance from all the hospitals. DHIS2 has been used now over 5-6 years. And we are developing a system for patient care, quality and safety. So that is also being used, implemented, will be on DHIS2, and another system for laboratory management information. So this is not LIS, this is like monitoring the indicators of related to laboratory services provided. So this is also being now discussed and being developed. So this will be available. And we are aligning with the recently developed National Digital Health Blueprint. So a complex diagram, but I'll focus on one area of this on the secondary data use. So this is where we are planning to use DHIS2 mostly, apart from the already implemented solution. So there will be like a digital health information warehouse, and DHIS2 will be a major component of that, and it will be used for data analysis, research, the planning and policy development purposes, dashboard. So all these components, DHIS2 will be a facilitator. Then how are we doing this? So many stakeholders involved. So these are the main stakeholders. As I mentioned, we started with capacity building with our master's and MD program in health informatics. And this was supported by University of Oslo, then University of Colombo, and postgraduate of Institute of Medicine. So we built a good team with DHIS2 capacity, not only DHIS2, but DHIS2 was a big part of those curriculums. And then we got support from University of Oslo through academies and other trainings, and then Ministry of Health. So we get on the job training from Ministry of Health. Once these people go for the jobs in Ministry of Health, we get exposed to different DHIS2 projects and then build our capacity. And HISP Sri Lanka is supporting all these projects through capacity building and expertise. So most of these instances, we have a support model where a 3-tier support model with a help desk and general technical team, mainly from the Ministry of Health, and specialized assistance from HISP and other special technical experts. And to support that, we have also developed a local community of practice with the DHIS2 experts and all the people who are implementing DHIS2 projects. So this is like a knowledge sharing platform where Ministry of Health is coordinating, and there's multiple channels of communication. And through this community of practice, we have improved the capacity, then a lot of collaboration was improved, and also the instances and all the implementations has become more stable with all the support. And also the interest in DHIS2. So whenever people come up with ideas, they think whether DHIS2 is also possible to be used. You must have seen a lot of interventions, and most of these are vertical. So that was due to a lot of reasons, a lot of administrative issues, then logical issues. So we are trying now to integrate all these systems, especially for decision-making level. So we have proposed this integrated public health information system architecture to get all the data for decision-making from all these vertical programs, and like which to facilitate the digital health blueprint, which I showed. So this is also in discussion now, and will be like a part of the digital health architecture in Sri Lanka very soon. So what is our final goal? So we want to promote DHIS2. I want to highlight the word appropriate here because that is more important. So appropriate use of DHIS2 within our digital health ecosystem, and also to build the capacity of the country, and then build institutionalize these systems so that the people in the Ministry of Health can take responsibility of these systems and run these systems to make it more sustainable. So finally, I think most of you have visited Sri Lanka last year for the Asia Academy, and I know they will be willing to visit again. And those who have not visited, I plead you to put this into your bucket list on the top so that we can see you in Sri Lanka very soon in this nice country. Thank you.
Corti. That's a brief about Palestine, small brief. Palestine divided to the 19 health districts in Palestine, 14 in the West Bank, and 5 health districts in Gaza. But our population is a small country, about 6 million, 3.5 in West Bank, 2.5 in Gaza. Total land are 27,000 kilometers. West Bank 5,500. Gaza 365 kilometers. We start DHIS from 2060. The first tracker system is MCH e-registry. In 2070, we scale up the team and create the HIS core team. In 2090, DHIS scale up and start with the tracker system like RTA, mammogram, NCDs, and etc. 2020, we saw, as you know, COVID pandemic, and we create surveillance and publish data to MOH site. 2001, we implement the family health record and registration. And we start pilot in 4 districts of 14 district. 14 district because West Bank, because all district in West Bank, and we don't have access to Gaza or other. In 2030, implementation 15% of district in West Bank. This data set for our program, how we started. بس في جدول مش مبين. الجدول مش مبين. ايش؟ There's a table. Minimize. There is a table. Table on. Okay. In 2017, the tracker system was one, MCHE registry. This is the first tracker. This is the first e-registry system in the HIS, and we have 9 aggregated system. Now in 2024, we have 31 tracker, 28 event, and 29 aggregated. First day, digitalizes process has considered the MOH probability. We have 380 clinic are using MCHE registry. 88 clinic use electron family health, especially in Selfit, Tubas, Jericho, and Bethlehem. This is a district in Palestine. Use a child, NCD, GB, and special visit, lab, drugs, immunization tracker. 14 districts are using HMIS, routine statistics, aggregated system. 100% are using case-based surveillance system. 14 districts are using mammogram. 14 is covered all the West Bank district. 14 district has all using digital health. 14 district using case-based surveillance and gender-based violence, GBU. 14 district using RTA. 14 district are using health education. 14 district use CRVS tracking. This is some number until end of 2030. We have a tracker instance entries 100, 140, and in MCH we have 295, and family health we has 195 record. Talk about MCH. MCH is a maternal child health care. This is the first project, first e-registry system on the HIS. The program has been successfully rolled out in 38 clinics across the country, out of total 38. And currently we support over 2,000 active users. family health program. This is the biggest one program, tracker program. It's like EMR, but not the same. You know, we can talk it unified record. Start from registry, family health file, then child program, immunization, pharmacy, library, radiology, accounting, and bin approach. Before before uh, before family health, we have separate program and separate tracker. Then we calculated in one instance, in one program. Our future plan is to migration with MCH and family health, and an MO integration with the insurance and MOI system, and then lab device integration, stock management module, and finance module. Our challenges, as you know, for finance and budget, team formula, formulation and governance, requirement management, stakeholder involvement, interviewation, change management, change request management, and communication, technical support. Thank you.
Thank you very much, Yusuf. All eyes on Gaza, for sure. Is there any question before moving to see Bangladesh experience? If no question, so okay. Hanan, please to present Bangladesh experience.
Thank you, Mohammed. So, good morning. I'm in front of you again to present with the Bangladesh case. First, I apologize because our government counterpart cannot make it to join this conference because of there is a political change in Bangladesh, and due to that, they can't give the government order to leave country. So I have to present on behalf of them. So first I show you the same thing. Every year I show the same thing, but it's not the same. So if you see, there is something changed. On my right-hand side is the Minister of Health. On my left-hand side is the Minister of Urban and Private. So you see the Minister of Health, the green boxes are all is done. And on the left-hand side, we just complete one urban health project, which is covering the significant part of the urban health area. So among these, there is some few achievements. For example, we achieved already Kalajor, the vascular espanthiasis, this elimination certification, which is we run one of the first successful tracker, where we track every Kalajor patient from scanning to treatment and follow-up. And we achieved the WHO, the Kalajor elimination certificate last year. So this is one of our achievements that we achieve, help government to achieve with DHS to track each patient, treat and eliminate the disease. So similarly, filariasis is also running the elimination phase, and we are also in the process to go for the malaria elimination program. And on the left-hand side, I go gradually everything step by step. So first we start with the reverse direction. So first we go to the Minister of Local Government. Minister of Local Government actually is responsible for the urban health, which in the urban area. So urban primary healthcare part is taken care of under Minister of Local Government. So here what we project working on is from 546 clinics over in 11 city corporation. You know that we have in the whole Bangladesh, we have 12 city corporation. We actually, the plan have 12 city corporation, but one mayor doesn't want to implement the health information system. So we have to go with the 11 out of 12, and for 18 municipalities. There's divided by 45 project areas. So there is comprehensive reproductive healthcare center, city maternity hospital, 157 healthcare center, and 334 satellite clinics. So what is the significance? This is a tracker-based system. So every service is provided to DHIS2 tracker at the point of care. So who providing the service, he's entering the data. So there is no other person there for entering the data. So actually, this is not use of any paper. They just do on the tab or PC. So there is no need of data entry operator. Nowadays, you don't find any data entry operator in any ministry. So that's the objective. And second step, at the end of month, automatically internal ADX has been done. So aggregate data exchange, this actual program indicator go to aggregate monthly data, and which is approved by the head of institute or head of facility. And then this ready for the quarterly report, which is every quarter produced automatically and go through the Asian Development Bank financial reporting, which is around 60-page report. So there's total 161-page report. Among that, 60 pages from our data. So what kind of report, including financial, how much patient they see, how much subsidy they provided, how much income they have. This is subsidized clinic and free also. So that's also calculated automatically. And linking data with the money is a good significance. The data quality is very good. So when we implement the system, there is some change in data. So we can very good, easily see what's the difference. Say, for example, earlier the delivery number of delivery the showing is less. The cesarean section was less. Now it's changing. Why? Because if there's a Caesar, they have additional money. So linking this with the money is actually improved. So and this actually is a few picture of the field where they're entering the data. You see, even on the river side. So these are the clinics. These are satellite clinics. So from there, and we use the DHIS to Android as an offline tools to use the data entry at the point of care. And what we do, we feed the data to the web portal. So the people can see their data publicly. So this is aggregate data viewable for public viewing. So if the data quality is not good, you will not give any data to the public. So that is one example, but this is not a static portal. So you have the dashboard menu where you can do your customized requirement. So you can have your own query and any chart, any graph you can see as per your requirement. But now look at this is one of the report which is going to Asian Development Bank, but I try to make several pages together. This is online. Also, what they do, they download it and put it with their main reporting in the MS. They actually do in MS Word. So we download in Excel and export it to the MS Word. So the 60 pages automatically made, and they are just actually put the reporting format and printed every month because the rule is they have to print. But if you see the data, this is the last quarter data. Maybe you cannot read at all. This is the resolution, but this is last 3 months, April, May, June. The total new client is 198,000. Total new client. Total service provided in that month is 2.6 million. Total service, 2.6 million last 3 months. And total after cumulative service we provided in that specific system is 45 million, 45.6 million. So imagine the scale. So this is example. This is publicly available dashboard. So you can see by yourself. I will share the link later on so that you can see. Now move to Ministry of Health. You know, the Ministry of Scale is also, Bangladesh is a very small country, but only 55,000 square kilometer, 1/10 of the Norway. But it has people of 180 million officially. Unofficially, a little more, maybe 19 million. But you know, the Norway has only 50 million. I am correct? So you see, 5 million. Oh, sorry. So in Dhaka city only we have 35 million. Dhaka city only. So that's the scale. The idea is when we design any DHS2 tracker, we should be very, very careful about the scale, how low we would go. And the data entry point, we have considered the many things. So let's move forward. So we are not only collecting data, we are also using the data. This is quite a few examples we are providing here. So we have the HSS scoring module, which is based on the WHO building block, which by WHO. So WHO actually requested to do this. So from every month's routine data, not only HMIS, also HRIS, logistics, everything fit in here to making the scoring of the facility. So what facility did? So we score which facility is scoring 1 to 10, every type of facility. So there is a competition among the facility for data entry and quality of the service. So not only data, we have also the survey. So there is a on-site survey. Someone visited with the DHS2 Android and make the survey questions. There's a grievance system that's also adding in the scoring. So this is one example how we facilitate. And this built on DHS. Some part is built on DHS2, some part is not. So it's actually providing to the portal. All is HSS is in portal. Second part is in monthly meeting decision entry and follow-up. So there is every month, there is a hospital management committee meeting. That's also feed into DHS2 so that the upper level, the centrally, they know which hospital management committee meeting, what decision was made and what the decision follow-up is. So if there is a hospital, say someone said that there is a toilet and other is unclean, so they have to clean those properly or not, whether it is follow-up. So there is several decisions they have to feed and write in the DHS2. So centrally, they can monitor what the complaint was, what was the management decision was. So hospital management committee meeting, this also similar. We have the community clinic, several meeting is also in the DHS2. So meeting recommendations and meeting minors is also in the DHS2. So they have to follow the management, not only service data as well. Another part is DLI or disbursement linked indicator. You know, the World Bank sector program, they separated $800 million for the DLI. So certain DLI achieved, and out of 14, 8 DLI from the DHS2. So from DHS2 data, if they are measured, they took quarterly report and go to the field. And they took the paper report, they took a username password from us, from the government, and go to the field, verify the data, go to the client and ask whether he or she is having this service or not. So randomly verify the data and approved the DLI. If that was achieved, then government gave certain amount of money. So that's actually improving the service. But the point is, from DHS2, we support this activity. So they are not depending on the third party. They are doing by themselves. So new thing we added is the IMCI tracker. We know the IMCI mostly we put as aggregate data collection. But IMCI we are introducing as a outdoor service for common childhood disease. This service provided includes our symptoms. So this is a sort of decision support system. So they just click on several symptoms. Say, for example, how the rhythm, how the breathing for 1 minute, how many times is breathe, what is the wheezing, is there any wheezing or not? He just puts yes or no. The decision will be made through our program rules. So for the program rules, we make the decision. Like e-register in Palestine, we also have e-register in Bangladesh, we also piloted. Similar way, we make the algorithm for these yes-no questions and decide the automatically assign the diagnosis and danger level. So there is a overriding system. Override, he can override, but he have to explain why is override. The system automatically generates aggregate data at the end of month from this tracker. So this is also, we are moving forward from aggregate data to the tracker to make the system automate to have the decision support system. Similar for Scanu tracker. So Scanu tracker is also new. The SCANO is registered with the patient ID and the address in the newborn ID. Because the newborn in my country doesn't get ID immediately because the newborn name usually settled within 2 weeks, not when his birth. So that's a problem. So we always name as the mother's name with the son or daughter of mother's name this way. And newborn assessment there is done in the SCANO tracker. This is also same distance support system. So they have to some use the question and this system make the decision. It can override the decision, but the important point is if this baby need follow-up, this community follow-up actually push to that specific location. Now our some area we are using piloting the OpenSRP. So we are trying this push this patient to OpenSRP. So look, this patient is going in the area, so you have to look up this specific child. So that is one way we are doing. So OpenSRP and those hospital has a Open MRS. We are also working on that, and hopefully by October we will also integrate with Open MRS. So SCANO tracker feature I already told, but this actually the screen is look like that. But I think due to resolution you cannot see much. I cannot see even. So there is also the notification provide service provider to call mother. So there is a SMS notification going to the service provider so that he or she can follow up her in the community as well. So another area is the NCD. So NCD cancer tracking, where we use the cervical and breast cancer follow-up. So cervical and breast cancer and DHS2 tracker in 43 districts, 441 sub-district, 8,000 community clinics are already implemented. So there is several stages. So not only screening, there is a community registration via screening, by visual inspection through acetic acid, clinical-based examination screening, colposcopy screening. This is a step-by-step. So one woman in one sitting, we include the cervical cancer and breast CBE screening via CBE, because usually we cannot get him twice. So when we get one chance, we're screening both. Similarly, many places we link with the gynecology department. So if every woman within the 30 to 60 year range is there, we can go for the mandatory cervical cancer screening. And that's actually helps a lot. And next stage is colposcopy screening and breast screening, where we use the mammography and MRI, where it's available. Then if it's positive, then go for biopsy and cancer staging and cancer management. We're working with the WHO cancer team in France to finalize the protocol with the cancer specialist. We have the several consultation. So we have the cancer staging and cancer management we also already implemented. So this is in progress because now only 4 hospitals. So yeah, 3 public hospitals and 1 private hospital is using the cancer treatment. So we have several other cancer hospitals, so gradually move forward to others. But the issue is we need for the cancer treatment, we need some specialized equipment, which they don't have. So government are going to procure those. But this is within the government system. So government can start rolling out by themselves, not by HISP. So HISP only now providing very core support, very small support, mostly run by the government. So NCD, that NCD also has a public dashboard where we can have this type of chart, where the same, there's an automatic chart and you have your customized one. So you can generate what you need from this dashboard. This is also publicly available. So you cannot have any tracker or personalized data. You can have no aggregate data for analysis. But is this aggregate data actually generated from the trackers? So those also we are providing the GIS mapping as well. Another NCD we have is hypertension and diabetes mellitus. So hypertension, we half of the country already scaled up. The issue is the hypertension and diabetes is we can roll out whole country, but the problem is we need 2 things. First is to measure the hypertension. You need the blood pressure machine, and the people know how to measure blood pressure properly. And second thing, we need the diabetic glucometer so that they can identify the glucometer strip and everything. And also if he's identified as a diabetic or as a hypertensive, then you have to provide the medicine. So this logistics, the associated logistics is required. So government actually moving slowly because when they can provide the supporting logistics. You see, so they have to monitor this way. So how much the cumulative patient and how much the new patient and control rate. You see the control rate is high. That was good, performing well. And the miss visit. So miss visit is also important. Who are missing the visit, so we have to alert the patients to come up. So thank you, everyone. This is from my questions.
This is a thank you in all language. Thank you, Hannan. Okay, is there any question for Bangladesh